there are a couple of sort of known facts in terms of gender inequalities. One of them is that women have on average longer life expectancies than men, but they live a greater share of these extended lives in poor health. And the other is that women are also more likely to provide informal care, although this changes slightly in older age groups. And against this backdrop, what FutureGEN is interested to gather evidence on is to see how much these inequalities are changing across different generations, across different cohorts, basically in response to changes to societies in mostly in Europe and Canada. That's mostly our geographical scope. So the number of changes in society taking place in the past decades, and we want to know how much that has impacted on these sort of known gender inequalities. We want to have sort of a dynamic view to what we know already about gender inequalities in health and care. Right. So on this, we have several work packages that are focusing on different aspects of these broader gender inequalities. We have one focusing specifically on health. We have one focusing specifically on care. And we're very much also interested in the intersections between gender and different forms of social location as it is. So to answer that, maybe I would sort of have a round between my colleagues so that each of them can sort of give some idea about how we are doing in each of these sort of work packages. Susan, maybe we could start with you, as you are our gender expert.
Okay, I'm the theory person. And I think you want to ask us subsequently how we define gender. So I'm going to start with that. Yes. And then go to, and what are we doing? So sex is, in my view and in the view of research over the last 20, 30 years, sex is usually considered to be the biology of being a man or a woman. And gender brings in social determinants of health and blends in other aspects of life, like race, socioeconomic status, location, social locations, to look more broadly at how who a person is affects their health. And so we have very much taken that view of gender. And you'll hear as we speak, sometimes we use the words incorrectly. So we may say gender when we mean sex, but we're working on it. And I think that is typical of all the research at the moment, that these terms get muddied. I actually prefer sex gender as the term because it implies the interconnection between biology and social. But more than looking at differences for men and women in health outcomes or in care requirements or caregiving, we want to consider what's referred to as intersectionality. So, for example, we may know that being male has this risk of a health outcome, being of color has this risk of a health outcome. But intersectionality implies what happens when somebody is male and of color. And there's preliminary evidence that is pretty clear that it isn't just an additive effect of the two social or two lived circumstances. So we are taking an intersectional approach. Okay. There's a lot of literature theorizing about intersectionality and grumbling about how nobody's doing it in quantitative research, and very little doing it. And so we wanted to start by examining how best to do this, because there's so many different methodological approaches to doing quantitative research. And so the work package that I led was a systematic review of research about sex, social locations, and a health outcome, any health outcome. And it was a review not of what they found, but of how they did it, to determine whether there are best methods for looking at intersectionality and its impact on health.
Okay. And did you find out like a
Yes.
good way to proceed?
Right. Good question. So that portion is actually done. There's a paper that is under review at the moment about it. We were very careful when we did the literature search to be very expansive and inclusive in our terms. So we ended up with 9,000 papers to review and whittled it down to about 500 that we did review. And interestingly, although there are authors who are adamant that this is the best and the only way to look at intersectionality, that was not our impression. Our impression was more that if you don't think about it, it won't be there no matter what methodology you use. And if you do think about it, you can probably work intersectionality into many methods. So certainly the non-starter were regression analyses that just controlled for sex. They didn't in any way look at gender or intersectionality. But hierarchical or multi-level analyses, structural equation modeling, even just sex disaggregating data in using any of the methods went some distance to including intersectionality as an input for a health outcome.
Regarding the data, I think we are dealing with two types of data as it is, or actually three, because as Susan mentioned, we have also a strong component that is reviewing evidence. But then we are using also secondary data sources, and we will have also a qualitative study that will gather new information about a number of issues that we're interested in across this sex, gender issues. And I think the one who's more advanced in terms of the empirical analysis, in terms of the work package, is Stefan. So maybe you want to say something also about the type of data that you are using, which follows very much closely also what we will be using in other work packages, and some of the challenges that we've been facing with the use of that data.
Right. So essentially in our work package, we've used two kinds of data. We've used readily available secondary sort of survey data, share data, essentially. But we've also done a literature review where we extracted sort of quantitative data from the literature that we found and reanalyzing those estimates. So these are the two kinds of secondary data that we used so far.
I want to say something to that because I'm the furthest away from everyone. Luckily, we did have a chance to meet in person before everything shut down. But even before that, I feel as if we set up really good and frequent communication via Zoom. It's always been via Zoom. And I feel as if we know each other very well and communicate quite clearly. So much as I long to go back to Sweden or Vienna or wherever for another meeting, I think it's worked well. I don't know what others think.
Yeah, I think that certainly the pandemic has created some challenges in terms of the way we had planned to work. Also, for example, in relation to the sounding board that we have, sounding board of FutureGEN, and how we wanted to collect their inputs regarding the research we are doing. But I think, as Susan said, our plan B has been to sort of meet more frequently over Zoom to make up for the fact that we'll not be able to be face to face in a very intensive way, sort of for 2-3 days in a conventional project meeting. And I would say that that has actually helped us to for each team to be much more involved at the different stages of the production of knowledge, because it's not that we kind of come together at a stage where quite a lot of the empirical work has been done, and then we are sort of picking each other's brain on how to analyze it, what we make of the findings. But we are actually sort of, as we go, we are exchanging ideas, sorting out doubts about how to approach one or another problem. So I think, as Susan said, we miss the sort of personal contact that is also very relevant to working together in a team. But the frequent contact has actually, I think, played out very well in terms of building knowledge and building on each other's strengths and expertise.
And I realize I'm speaking a lot, but because we're able to connect virtually, the whole team meets. So there are about 10 people who are part of the team. And there are people, we haven't told you about the qualitative component of our research, but that's another set of data that we are collecting. And the three people you're talking to now are not qualitative researchers, but because we're all there all the time, I think we've learned a lot, we've contributed a lot, and the qualitative researchers have actually asked very good questions about what the quantitative researchers are doing, because sometimes it doesn't make sense to them, and sometimes they're right that it doesn't make sense. So in a way, I think it's been an advantage that we've been forced to sit in our homes on computers.
No, we definitely start to have already early findings, and apart from one of the review papers that Susan alluded to, that is already undergoing actually the revision process in the peer-reviewed journal, we are also arriving at a point where very soon other empirical sort of pieces will follow, and again, deferring to colleagues, maybe Stefan, you want to say something about early findings of your cohort study, and then I can also follow up with some of the early results we have from the studies we have related to care.
Sure. So what we're doing right now is that we trying to track abilities among men and women in Europe over birth cohorts to see whether the sort of magnitude of gender differences have shifted as the gender relations have shifted. Okay. And what we found so far is that there are pretty stable gender differences in health. Women have more disabilities than men at pretty much all ages. And they seem to be fairly stable across cohorts with one exception, and that is Eastern Europe, where it seems that women have benefited a lot lately. So later born cohorts of women have better health than earlier cohorts of women at any given age.
All right, interesting. Is it all countries of Eastern Europe, or is it?
Oh, I should know. It's not all countries. I should know which one, but I don't know by heart.
Yeah, okay, it's all right now.
Maybe Poland and Czechoslovakia and Czech Republic. I can't remember.
Yeah, those are in there. I'm not sure if there's one more or not.
Okay.
I think that the issue in this cross-country comparison is certainly one aspect that we are very much interested in the context of FutureGEN. But one challenge we sometimes are faced with is, of course, sample size. And very often we are forced to lump countries together according to a number of characteristics that we feel are relatively common for us to be able to analyze it. Of course, there is always the danger there is some loss of analytical capacity by the fact that we are lumping together these countries, and you know, it's if you think of the welfare regime literature, if you ask 10 researchers, you probably get 15 typologies in terms of care regimes. But still, we find that in a number of, or concerning a number of the research questions we have, this provides us with useful lenses to analyze differences and similarities. And I use this also to introduce a bit what we were doing in the work package related to care, because there indeed, and that's also why I usually use more the term gender rather than saying sex gender. Usually there is also an aspect where the social constructs around gender and also the public policies around care play a very important role in terms of the differences, gender differences we find in care use and caregiving across Europe. And we currently have one study that is practically finished, where we are looking at the impact of widowhood on access to different forms of care in old age. And one interesting aspect, I think, that we have in this study is the fact that transitions into widowhood seem to have an impact on women, but not on men. So older women, when they transition to widowhood, they somehow are able to access care. They even increase their probability to access care, and this we don't see with men. Men are much the results for men are relatively more stable. And again, the interesting aspect, I think, of this research is also that this does not change when we consider different living arrangements. So this remains in place, even if we account for the fact that, for example, older women are more likely to move in with their children in old age. And again, we find also some differences across these sort of care regimes, and we are trying to explore that further in terms of trying to understand what that tells us about either social norms or public policies and how they are impacting the access of this particular group, people who have recently transitioned into widowhood, their access to care.
Right.
And I just want to add to that. So one of the challenges or the dilemmas of using large data sets is that one has to just accept the data as is. It can't be interrogated in any way. And we're recognizing, and we are not the first to have recognized this, that how men and women, or how different groups define the variables that are being asked about will change their answers. So women probably define self-rated health differently than do men. Women probably define yes, I need care, or no, I don't need care differently than men. And that's behind all the output. And some of one of the aims of the qualitative research will be to actually go to a certain number of older adults in each of the settings and ask them to explore these concepts further. So, yeah, the problem is that the Canadian data doesn't mesh with shared data. And we're really working to find a data set that can't necessarily be used for a kind of meta-analysis, but where we could at least do the same analysis and be confident that we're using similar variables and with a similar outcome.
Okay. All right.
Yeah, I think what Susan just said in terms of this, how far men and women think about care or health in different ways is one of the reasons why we have so far been using data sets that are relatively at least comparable across countries, rather than using just individual level national level data sets, where we would perhaps be faced with much greater constraints in terms of whether we are measuring one phenomenon in the same way. So that's definitely been, I think, behind some of the choices we've done in terms of using larger comparable data sets, such as SHARE, for example. We're looking into others instead of trying to pull together sort of national sources of information that then could be, or most certainly, unfortunately, would be much less comparable. But yeah, but unfortunately, it is a challenge how to integrate European data with data outside of Europe. And that's definitely, I think, one aspect that this, I'm sure other projects have already, I think,
Absolutely.
highlighted
Yeah.
of a gap in terms of data infrastructure.
Mm-hmm.